And when you're talking to patients about just polyps in general, how do you explain nasal polyps? Because I think sometimes patients hear polyp and they think, about polyps in other parts of bodies, like a polyp in the colon, which, could be precancerous and that you can just remove. Or they might say, like, can't you just take it out? And you kind of have to have that conversation about the uniqueness of nasal polyps. What does that conversation look like for you?
Well, a lot of times you can just you can watch the patient's reaction if they think it's something like a colon polyp, right? And then I'll just say point blank, this is not like colon polyps. It's a completely different game, just to take that off the table if I get a sense that they're just super nervous. What I do explain, though, it's just basically about inflammation that is triggered for unclear reasons in a specific patient. And I'll even go further and say it's like a lot of chronic diseases that, everyone experiences, like hypertension. Why do some people get high blood pressure? Some combination of a genetic predisposition, some bad luck, and some ill-defined environmental trigger, right? Almost any chronic illness falls into that category. And it's very hard to go deeper than that in any one patient without doing, these exhaustive studies that are not really clinically relevant. And most patients will accept that type of explanation.
It can be a hard conversation though, because sometimes for some of them, if they're young, it's like their first chronic, disease where it's like, "Oh, this is something now that's I have to consider lifelong or take care of. It's something else to think about." And so I've had some patients where that it's taken several visits to really understand that, oh, this is something that isn't just gonna go away, even, in multiple discussions, about it.
Well, the advantage there is you're dealing with a clean slate, though, in terms of what that patient's expectations are.
Yeah.
I mean, some of my favorite patients are, kids I saw in high school, and now they're through college. They just come back for checkups. They're allergic fungal sinusitis, and they completely understand the disease process. They don't cold all the time. And it's very cool. They come in and they'll show pictures of their kids now, which is really neat because I knew them when they were in like ninth grade. And we managed them through the whole way, and the disease kind of burned itself out, and they're just doing fantastic.
You mentioned that there are some patients that maybe can't have steroids. Can we elaborate on that piece a little bit more?
I don't think there are very few absolute contraindications to almost anything that we do. That patient group would mostly be diabetic patients. And even there, you can go down and say, do you check your glucoses, get a sense of how severe their diabetes are, work with their endocrinologist. So it's manageable. You just have to do a little bit of extra work. If it looks like they're not a candidate at all we can rely on are the topical treatments. And I think that's fine because the amount of absorption you're going to get from a topical steroid treatment, it's not zero, but it's not going to be enough to trigger significant hyperglycemia, right? So it's manageable. But that's not that for some reason it's not as common today as it seemed to be years ago. I don't know if endocrinologists and primary care doctors are better at managing diabetes or we're using less prednisone. But it seems to be less of an issue today compared to 15 years ago.
Yeah. And what about patient preference? Like, do you have people who are just, you mentioned prednisone and they're just like, ooh, I don't want to take steroids. Is that,
That comes up whenever I start the prednisone. We have some, standard discussion points around bone metabolism, irritability, hypertension. Weight gain is a thing that gets most people. I just review the pros and cons. I mean, we may go more toward a little bit of a shorter course than a longer course, but I explain the idea that it's just to sort of jumpstart things so that we can rely on topical. And most people will go along with that.
and is there anything else? Like, have you ever had patients who say, like, is there anything I can be doing about my, lifestyle, diet, environment to help this?
It depends, really. So some patients will look up and they come in and start talking about salicylate-free diets. If you have aspen triad, and salicylate-free diet does make sense. The problem is very few people can do it because all you can basically eat is cardboard. It's almost an impossible diet to stick to. Modifying those behaviors sounds great, but in practice, people can't sustain it. And then the other issue is that people are going to make a major effort there. I think we should be able to tell them, yeah, this is going to make a big difference for you. And we really can't, right? And so they would go through all this effort, end up exactly where they are. That's not helpful either.